Hi, everyone. Welcome back. Today, we're joined again by Dr. Eddie Stenehjem to give our weekly COVID-19 update for the state of Utah. Dr. Stenehjem, as always, thanks for joining us.
Thanks, Amanda. Happy holidays to you.
Thank you. You too. I want to start with case trends like we normally do. The numbers for today were actually just released, so the data I will be talking about is for today. Our total case counts in the state of Utah are 257,697. The daily case count for today was 2,615, which makes today's positive rate 27.2%. The overall 7-day rolling average for that positive rate is 23.7. Our deaths are at a total of 1,196, with 24 new deaths reported today. The hospitalizations are at 10,327, with 560 today, and our ICU referral capacity is at 92%. As we reported last week, the Utah Department of Health is also reporting vaccine totals, and we are at 11,380 people have been vaccinated so far. Dr. Stenehjem, let's break that down a little bit. How are we doing? What have the trends been since the last time we've spoke?
Yeah, we're in a nice kind of downward trend of our case counts. I mean, if you look at the Utah Department of Health graphs or any number of resources, what you're seeing in the state of Utah is that the numbers are coming down, which is, incredibly encouraging. That was after a small spike after Thanksgiving, and now we're kind of still seeing a trend down. You do have to kind of think also about the fact that our number of people tested isn't back up to those levels we were pre-Thanksgiving. Pre-Thanksgiving, we were testing almost up to 20,000 people a day. That's now come down. It's been relatively stable, but not nearly as high as it was before Thanksgiving. As such, when you look at the test positivity rate, today was reported at 27%, yesterday was 27%, and then the 7-day average currently right now is right around 23%. That's still really, really high. We really want that to be less than 5%. So, what that tells us is, yes, our case counts are down, very encouraging sign. And we've got some other indicators to show that we truly do have decreased community transmission. And we'll talk about those in a second. But our testing volumes aren't as high as they could be, and our test percentage is high, just meaning that we're likely missing a lot of active cases in not getting tested. But certainly encouraging, especially as we come into a holiday. If you look at our hospitalization trends, what you'll notice is that they're still really high, but they're not going up. And if anything, they've come down a little bit. And so our daily censuses across the state has stepped down. They were plateaued, now they've come down a touch. But our ICU capacity in both our referral centers and general ICUs is still really high. I mean, they're better. It was 102% earlier, this week. They're now down to 90%. That's a measure that's going to take a while for it to get better because those people in the ICU are there for a long time. They need to either graduate from the ICU, get better enough to be able to floor, or unfortunately pass away. So that we'll see hopefully get better, over time. What ideally we would have seen is to have our numbers be really low before the holiday and New Year, which would then decrease any kind of risk of transmission amongst families that are gathering. But we still have really high transmission rates, even though the numbers are down. So we're encouraging. We're definitely moving in the right direction with numbers down, but our big kind of obstacle to come right now is the Christmas, New Year's holiday, and what is that going to have on our impact? Ideally, we would have had hospitalizations down even further to then accommodate a surge that we have to anticipate is going to happen. But unfortunately, our hospitalizations are still high. So fingers crossed that, Utah comes together as a community like we did in Thanksgiving. We didn't see that big surge we were expecting because Utahns took this seriously. I'm hoping we'll see the same thing out of Christmas.
I want to talk about the death rate really quickly. It seems to me that it just keeps going up, or it's pretty steady. Is this something that we were expecting to happen? Should it be going down by now since our cases are going down, or is this pretty normal?
No, this is, unfortunately, like we talked about last week, this is what we'd expect. That death count is a lagging measure that's going to come, weeks later after cases and hospitalizations and ICU admissions, and then it's going to be deaths. So the fact that we're still having these high numbers is not unexpected. And when you look deep into the data and you look at the demographics, you've seen a bit of an uptick, or not as quick of a lowering, in that 85-year-old plus group, which is one of the unfortunate predictors of death when you get COVID-19.
I want to switch gears really quick to something that's been in the media. The UK has been reporting a new strand around COVID-19. Can you break that down for us in layman's terms? What do we need to know, and what are the implications for us in the US with that?
Yeah, so there's been a lot of talk of what's called the UK variant. And so, viruses, bacteria, they replicate quickly, and they replicate often, especially when people are infected. With that replication, there's many times errors in the replication process. And so some of that DNA of the virus gets mutated, and you get some small mutations that may or may not have any impact on the virus at all, and some mutations, however, cause a virus to be what we call less fit, meaning that it's not as likely to cause an infection in humans, and it doesn't replicate as well. Other mutations may be beneficial to the virus, not beneficial to humans, but beneficial to the virus, and lead to increased transmission or severity and those types of things. And so we expect mutations that occur. That's just part of virology and bacteriology. And then look at influenza, for example. So what's happened now is that in the southern part of the UK, they've seen a rapid rise in a certain strain of SARS-CoV-2. And this variant or strain, whichever word you want to use, has 23 mutations. That's quite a bit when you compare it to the original virus that was sequenced back in January from China. And so it's a number of mutations. About 7 of those mutations are in called that spike protein and that spike gene. So the gene that encodes the genetic information to make the spike protein, which sticks on the outside of the virus, which then attaches to our human cells and allows the virus to enter into our human cells. There's been about 7 mutations in that genetic sequence. And then 1 mutation that's been in what's called the receptor binding domain of the spike protein. It's hard to get into the details, but we'll see why in a second. That receptor binding domain is really what allows it to attach to ACE2 receptors on our human cells to allow entrance. And so what we saw is that this was first identified back in September in Kent. And then in November, it accounted for about 20% of cases. And now in December, accounts for about 60% of cases in London and in the southern part of the UK. And so we saw this rapid rise of this new variant. Now, the question is that rapid rise of this variant due to the mutations in that genetic sequence? Maybe those mutations are making this more contagious, and maybe it binds better. And so the reason you're seeing now 60% is because it's just more contagious, and that's the most fit virus, and it's going to spread the quickest. Or you're seeing this big increase because maybe this virus, developed spontaneously and now got into an area that had a super spreader event and just went gangbusters across London and other areas just because of the behavior of the people. And so whether or not it's more transmissible or not is under evaluation. Some scientists say, yeah, it looks like it might be, but those studies are ongoing. The other questions you need to ask ourselves is, okay, there's the transmission bit, but does it cause more severe disease? Do people die at a higher rate if they get this variant compared to what we call the wild type? And so far, it doesn't look to be the case. It looks like it causes the same SARS-CoV-2 or COVID-19 infection that the wild type does. So that's one thing to keep an eye out for. And the other big thing to look for is our vaccines that are currently out there, Moderna and Pfizer, going to protect you against this variant? And we think the answer is yes, it will. But the 2 groups that have these vaccines are looking at this and studying this in the lab to determine whether or not the immunization leads to protective antibodies and T cells response that will respond to this new variant as well. So unfortunately, lots of unknowns right now. You're going to see lots of work on this in the next couple of weeks. There's going to be a lot of busy scientists over the holidays trying to untangle some of this. But as it stands right now, we think that the vaccines will be effective against this variant. We're watching this closely. And I know the CDC will be starting to do more sequencing to see if that variant is here in the US.
You kind of just answered a question I was going to ask you around if Intermountain has created any sort of testing to figure out that strand is here. It sounds like that process is maybe starting with the CDC.
Yeah, so the challenge is that in order for you to determine if this variant is here, you have to sequence the whole genome of the SARS-CoV-2 virus. That's not something that we do in our standard labs. That needs to be done at a sequencing lab. The UK happens to have a very good national sequencing program that does epidemiologic monitoring of these viruses. So they've sequenced many more whole SARS-CoV-2 genomes than we have in the US. And I saw one report that the US is well behind the UK in number of sequences. And we have many, many more infections. And so the CDC, I think, will be starting this program to be looking at surveillance and trying to identify that. That's not something that traditional labs will do to determine whether or not we have that here circulating in Utah. I suspect that there is this variant in the US in some places. I mean, if this variant has been present since September and had 20% in November and now 60% here in December, knowing how many people travel from the UK to the US and vice versa, I think it's almost assured that we have this virus somewhere in the US. And I think Tony Fauci talked about this either today or yesterday as well. I think it's inevitable for us to see this because it's now 2.5 months into this being a pretty dominant virus.
I know the UK went into a pretty extreme lockdown recently because of that. So it'll be interesting to see kind of what comes from that and if it has any sort of positive effect on what's happening with that new strain as well. So
Right.
I want to quickly talk about testing. I know we mentioned earlier about the fact that our case counts are going down. It seems like testing potentially in the state is also going down. Is Intermountain testing at the same capacity or at a higher rate that we normally do? Has it been pretty steady throughout the entire pandemic?
Yeah, our levels have been pretty steady. We still have capacity to potentially increase our testing. We've had to make some changes in the way we do it as we head into the winter months, but we still have this capacity available to us. We expect that after the new year that we'll start seeing increased testing. The governor mentioned this back about a month ago. They want to increase testing, especially in colleges and in high schools as well with antigen tests. So I think we're going to start seeing that pick up. And so we're going to hopefully see more testing through that program. And then another thing to consider is that the FDA just approved the first home-based COVID-19 test. And so I think after the new year, you're going to probably start seeing more and more tests available people in the home that you can self-administer and read. And we're going to have to be really careful in terms of how we educate people on how to use that. And we'll have to really see how good are those tests. Are they good enough where we can fully believe the results at that moment in time? Or is it something that we have to do sequentially and do multiple tests over the course of a week or so? So I think you'll see things evolve over the next few weeks in terms of increased access to testing.
And on that note too, I just want to mention our testing sites tomorrow have adjusted holiday hours. Most clinics close at noon tomorrow, with the exception of Cottonwood Heights Clinic is open until 1 p.m. And then this is for the testing sites for COVID. And then all of our testing sites are closed on Christmas Day, so on Friday. So just keep that in mind if you're looking to get tested. Another question for you around hospitalizations. Can you describe what it's like for you and your staff to see these people alone during such a hard time? You mentioned to me earlier, you're rounding tomorrow with COVID patients. It's Christmas Eve. What is the atmosphere feel like in the hospital right now? And are our caregivers doing anything special to kind of increase the happy and the mood there?
Yeah, I can tell you, being in the hospital and now having 6,000 or so Intermountain caregivers vaccinated, that the mood is a bit lighter. We all felt comfortable in our personal protective equipment. The N95 mask, the goggles, the everything we use to keep us safe. We felt safe with that. But now that we've been vaccinated, or most of us have been vaccinated, that just gives us a little bit more of a sense of safety. And so it's a feeling of safety for our caregivers. So that has helped us tremendously. And I'm just so proud of our caregivers to, just stick with this and get the vaccine. And they're feeling a little more safe these days. It is a tough time to be in the hospital. It's a really hard time both to work in the hospital and be a patient in the hospital over the holidays, especially when you can't have visitors, for these COVID-19 patients. And so we're really encouraging those patients, obviously, to connect with their family and their friends through FaceTime, to really engage with them as much as they can, because we know this is a really hard time on people, not just the patients in the hospital, but also their family members being at home without their loved ones, knowing that they're ill, knowing that they're in the hospital, uncertain of how well they're going to do. It's really hard. And then it's hard on the caregivers too, to be away from their families, taking care of, patients that are suffering. And we also aren't encouraging, potlucks and people bringing in food. I mean, that's always such a tradition in hospitals, is that, on these holidays, doctors and nurses bring in food, and you have a meal together, and people are sharing food and getting together and making the best of it if you're in the hospital. And that's not something we can do safely right now. And so we try to lighten the mood as much as we can, and we try to get, patients to, also connect with their loved ones through FaceTime and those things. And so, but it's hard. It's hard to kind of be there in these moments.
And I know some of our hospitals too have decorations up, or like words of encouragement. There's some walls up for people to look at. So hopefully that helps bring up the mood a little bit. But yeah, I can't imagine spending the holidays in a place like the hospital. So yeah, that's a very sobering thought. Sorry, go ahead.
There was an ugly sweater contest at our hospital.
I like that.
Little thing.
That's fun. Another quick question around that as well. You mentioned the death rate kind of earlier, and how we kind of are seeing it staying the same. Is there any indication of when the death rate could start to go down, since our case counts have seemed to be going down a little bit?
Yeah, I think the first thing you're going to see is a decrease in your ICU volume. And so, as you start seeing that ICU capacity increase, our ICU census decrease, then you're going to start seeing death rates, decline. And so until we don't have our ICUs full of people with COVID-19, until that happens, you're going to still see high death rates, unfortunately. And so we hope, if this trend continues in terms of a decrease in case count, which will lead to decrease in hospitalizations, which are going to lead to decrease in ICU stays, you'll then start seeing a decrease in deaths. What I worry about is that we are now going into this Christmas and New Year's holiday, and that very well could potentially drive our cases back up, drive our hospitalizations back up, drive our ICU volumes back up, and our death rates will remain high. And so when we kind of think about the next 3 months, and I use 3 months as kind of an arbitrary value, but 3 months is when we, many people across the US in Operation Warp Speed think that we're going to get pretty significant vaccination to people that don't work in healthcare or are non-essential workers. If we can get through that 3 months, then, I think we're really going to be kind of towards that light at the end of the tunnel. But I really think the next 3 months are going to be really critical. And the next 2 weeks is probably the biggest barrier to get through as we move through these next 3 months.
A question along those lines too: how can someone show their appreciation for a healthcare worker during the holidays? Do you have any suggestions on what someone could do so that they can kind of show their support?
Well, I would say the biggest thing you can do is be an advocate for our public health measures. And not only, do them, which so many people are, and we are so, so grateful for that, but spread that message. Spread the message of, hey, listen, we need to do this together as Utah. This needs to be a community initiative, and we can get through this. And the biggest favor you can pay us in healthcare is to be a vocal advocate for those measures. So whatever means you have to spread that message, to tell your friends, tell your family, and be a good example. that would be the best gift you can give us in healthcare, because what that'll do is that'll reduce the number of people that get sick and the number of people that die from this virus.
It's a great reminder too, and we'll switch to vaccines, which I want to bring that up again, but really quickly, a question around testing. Someone asked, are there any plans for when Intermountain will expand testing to people who are not experiencing COVID-19 symptoms? And could this help public health officials better understand the scope of the infection in the state?
Yeah, it's a really good question, right? So now you're asking, when can Intermountain really move into, fully into public health, right? Because right now we're there as a resource if you are ill, and we can diagnose you, if you have symptoms, or if you meet in one of these categories where you have to travel and have a negative test, those types of things. I think what you're going to see, as we move on, is the technology of mass testing is evolving. And so right now our limitations are reagents, our lab workers, our space, all of those things. I mean, this is a pretty laborious test. And so once we, evolve that technology as, a medical group, and we can do these mass platform testing, and once some of these companies that are developing these rapid kits are able to produce the volumes that are needed for widespread dissemination, that's when we'll be like, yeah, let's open up, let's do this, whether it be an urgent care, drive-through site, whatever it might be. But those rapid kits right now, some are coming from a company called Cepheid, BioFire, there's a number of places that do it. They're in short supply. And so we're using those rapid kits where we got to have an answer quickly. For example, in the emergency department, somebody being admitted, we got to know if they have COVID-19 or something else. So once we start getting more of those from suppliers that, are supplying the entire US and sometimes entire world, once we can get more of them, and once we get technology that allows us to do our in-house PCR testing on a larger scale, that's when you're going to start seeing more of this. I also think that you're going to start seeing much more, like I said, these home-based tests that potentially could really increase access to testing as well.
I want to switch gears to the vaccine. It's been a week roughly since you've gotten your first dose of the vaccine. How are you feeling? Have you had any side effects at all?
Yeah, no, I feel great. I just realized I have a banana on my shirt, and that's been incredibly distracting, but I'm going to leave it there. My daughter just got
I didn't notice.
For Christmas, and I went up for lunch and she gave me a sticker. So I'll just leave it there for now. Don't let it be distracting, Amanda.
You're feeling good.
Good. I feel totally fine. So I got vaccinated on Thursday, last Thursday. I had some arm soreness, some muscle soreness for about 24, 36 hours. It wasn't any worse than a flu shot. This year's flu shot, for some reason, I had muscle soreness for about 48 hours, but really, wasn't that noticeable, but, certainly was present. That evening, I felt a little tired. I don't know, I was hyper vigilant for what symptoms I had because I'd just gotten this vaccine and I knew people would be asking. But I think I was probably a little more tired than usual. That next day, that Friday, I worked a full day, no issues, no fevers, no real muscle aches, no noticeable fatigue. And then, maybe a little more tired. I don't, again, I was perseverating on these symptoms. And then Saturday, I was totally back to normal. So I could say I'm minimally symptomatic from the vaccine. When you look at the data, the second dose is usually more reactogenic than the first dose. And so I expect that when I get this second dose in 21 days, because I got the Pfizer vaccine, we'll probably have more symptoms. But the first dose was incredibly mild. And, I kind of polled our infectious disease group and some of the hospital-based people that got the vaccine. And people had very similar kind of reactions, very mild arm soreness and minimal, if any, systemic symptoms.
That's good to hear. And we'll definitely check in with you again on your own personal experience after that second dose. You brought up that you got the Pfizer vaccine. I want to quickly talk about the difference between the two, the Moderna and the Pfizer one, and what types of areas would potentially get the different vaccines.
Yeah, so the two vaccines that have been approved by the FDA under emergency use are the Pfizer and the Moderna, with the with the Moderna vaccine just being approved last week, or actually last weekend. The vaccines are very, very similar. They're not identical, but they're very similar. They both, have an RNA strand for the entire spike protein. The difference is in the vehicle in which that RNA is in, and that's a lipid nanoparticle. That is something that allows the RNA to enter into the cytoplasm, so the part of the cell that has the machinery to make the protein, not into the interior nucleus where the DNA is, but it's in what's called the cytoplasm. That's the difference between these two, is really that vehicle in which that RNA is transferred into. Because of that, the Pfizer vaccine has to be kept ultra cold, minus 80-degree freezers, whereas the Moderna vaccine can be kept in standard freezers. It doesn't have to be that ultra cold temperature. That's the main difference. There's some subtleties. Moderna is 2 doses 28 days apart. Pfizer is 21 days apart. When you look at the safety profiles and the efficacy, essentially identical. Okay, so how that impacts in terms of distribution is that many and most, I would say, clinics and small hospitals don't have minus 80-degree freezers. Like, that's something that large care centers have. That's something that research facilities have. And so that limits where the Pfizer vaccine can be sent. And that's one of the reasons why you see it at our large facilities, is because we have the minus 80-degree freezers. The Moderna vaccine doesn't need that. And so we suspect that that will then be sent to both clinics and also to our smaller rural facilities that can then use that vaccine instead of the Pfizer vaccine.
And along those same lines too, do we know anything, or has there been any more data that says how often we're going to be getting the vaccine? Is it a once a year? Do we not know? Every 5 years?
We really don't know for a couple of reasons. One is that we don't know how long this immunity will last. And so that's going to be something that they look at very carefully in these trials. The people that are in the trials are in it for 2 years. And so they'll monitor in that 2-year period, well, what does antibody levels do? And also, when do they start seeing new infections in those people that were immunized? To be able to say, okay, how long does immunity really last? Is it 1 year? Is it 2 year, 3 year, 4 year? We don't know at this point. We know that from just data observationally that it looks like, once you've been infected, you have a number of months of protection, likely at least 6 months, potentially longer, but we just don't know how long both natural immunity, meaning immunity that you get from infection, or immunity you get from a vaccine, how long that lasts. And so we won't have any good idea on that for, probably quite some time. We anticipate that it'll be, at least a year, potentially longer, but we just have to follow the data in terms of how well antibody levels correlate with protection. That's going to be one thing to do. And the other thing to really keep in mind is what's happening in the UK. And so if we start seeing mutations in the spike protein, which is what we develop our immune response to, similar to flu, if we're starting to see significant mutations in that protein, we may have to revaccinate with a different vaccine to accommodate those mutations. And so lots are going into that. And unfortunately, we don't have an answer in terms of what that interval will be.
Sounds like we will just have to kind of wait and see and figure out that's interesting that people stay in the clinical trial for 2 years. I didn't know that. So that'll be interesting to see kind of what happens with those people. Another update question for you is just around the general public. We've kind of been hearing mixed messages on a timeline, and I know it's not secure. There's not like an end date of March 1st. General public will get it. But do we have any updates on or any information on when that could potentially be?
Yeah, so this is something that, we're really at the mercy of Operation Warp Speed, and then also our national guidance. And so when we can get into general public, and you could say, well, what is general public? Is that just public that are age greater than 65? Is it people with medical conditions? What does that mean? We really are at the mercy of Operation Warp Speed and the manufacturing processes of the vaccines. And so it's fully dependent on how much vaccine we are being shipped in the state of Utah. And then we will be following the guidance of the Utah Department of Health in terms of who goes next. Those aren't decisions that Intermountain Healthcare makes. It's not a decision the University of Utah makes or St. Mark's or any of these groups. How vaccines are distributed is fully dependent on the guidance from the Utah Department of Health. We will follow their guidance. We will act in their state to vaccinate people, but we do it based on what the Utah Department of Health guides us to do. And so that process is that the CDC and ACIP has come together and made recommendations of phase 1A, 1B, 1C. If you remember, phase 1A was healthcare workers and long-term care facility residents and workers. That was 1A. That's what we're in right now. And then they announced phase 1B and 1C. Phase 1B, meaning people above age 75 and those with chronic comorbid conditions. And then phase C goes down to 1C goes down to age greater than 65 and all other people with medical conditions. The state health department will take that guidance from CDC and Utah and ACIP and then say, this is what our Utah program will look like. And then we will, just like the University of Utah and other healthcare organizations, will follow that guidance from the Utah Department of Health and vaccinate to that schedule. And so we really are dependent on those things. And we hope that we're starting to see people getting vaccinated, in the coming month, end of January. But it really is dependent on so many of those factors that it's really hard to put a date on it.
It's good to know, and that's good information about the state kind of creating this criteria about who gets vaccinated. I want to end the discussion today around holiday recommendations. Christmas is on Friday, and there's also lots of holidays. And like you mentioned, the next 2 weeks are usually typically about gathering with your families and having these celebrations. My first question for you is, the weather hasn't been too cold, shockingly. It's been a pretty mild winter so far. Do you think this impacts the current numbers? And are you worried that if we do start to get this colder weather, our numbers are going to go back up?
Yeah, you're right. The weather hasn't been terrible. Hasn't snowed a lot in the valley or in the mountains. And so that has allowed people to gather outside. I know that, our social circle, we've had, some gatherings on the deck. We have a space heater and one of those lamps, and we've been able to do that safely. And so I think that has helped encourage people to be outside and enjoy that time with other people. I do worry that as the weather gets worse, that's going to drive more and more people inside, and that's typically what happens in January and February. And so it is a concern, for all of us. And then the holiday is a huge concern.
And what do you feel like we did right at Thanksgiving that resulted in this smaller than expected uptick? And what are your recommendations for Christmas and New Year's to ensure that we don't see this bump that we feared we were going to get?
Yeah, you're right. I was pleasantly surprised. I thought for sure that we would see a big bump after Thanksgiving. And I think I underestimated our community. And I think what we did well is people took that advice and they took it to heart, and they didn't have large gatherings. They didn't gather with people that were at high risk, elderly people with medical problems. And I think they just said, yeah, we got to do this year. And we'll look forward to the summer when we can get together as big families again. And I really hope that, again, is what happens for Christmas. And we really, even though we did really well after Thanksgiving, we've seen some really sad stories in the hospital in the past couple of weeks of the consequence of large Thanksgiving gatherings. And there's been a number of cases where we've had grandma and grandpa both in the hospital with COVID-19 after a Thanksgiving Day event. And that's just tragic to see. We've seen that, unfortunately, multiple times. It just hasn't been at the level that we originally anticipated. So I think what we did well is that people heeded that advice. And I'm hoping that that's what's going to happen again this year, tomorrow for Christmas Eve and the day after for Christmas Day. And then also into New Year's, is that, you don't gather outside of who's in your home. And if you do choose to gather, you're really careful in terms of who you gather with, in terms of small numbers, and you don't gather with people that are at high risk or have exposure to high risk people. And so really think about, who are you gathering with? What is their risk profile? What's the risk to them or to you if you get infected? And then who are they going home to? And who potentially could they infect if they get infected at your gathering? And so I think it's saying, hey, most conservatives don't gather outside of your home, period. And the second one is, if you do, be smart about it. Really limit the number of people in your home and be careful with anybody who's at high risk. And if you're at high risk, I'd say don't do it. Don't gather. There's just too much community transmission that the chance of somebody coming into your home that is asymptomatically infected or minimally infected is just too high to chance it.
Those are great recommendations, and I appreciate your honesty around the two different types of gatherings that people could have. Is there anything else that you wanted to mention today before we wrap it up for the holidays?
No, I mean, this has been a really hard year on all of us. And I love the fact that we now have 11,000 people vaccinated in the state of Utah, as reported by Utah Department of Health. I mean, it's just incredible. We just started vaccinating, 10 days ago, and we already have 11,000 people vaccinated. That's just so amazing. And I'm just so looking forward to being able to vaccinate more and more people to allow our communities to be safer. And there truly is a light at the end of this tunnel. That light is still a ways away. It's months away. But at least now, as opposed to 2 months ago, there's a light there. We've got an endpoint. We know where we're going. And it's just a matter of getting there safely. And people know what to do. I mean, people are tired, sick of this. I'm one of them too. But we know what to do. We know what works. And that's such a much better situation that we've been in before. And so I would just say, hang tight, do what you need to do from a mental health standpoint, connect with people through whatever means, go for walks, but bundle up and whatever it might be, just hang in there. We'll get through it. And we'll hopefully look back at this time, in 4 months and reflect upon it. So just appreciate everybody doing what they can.
Well, thank you. That's really good advice. And hopefully 2021 is our year. And hopefully I didn't just jinx us. But thank you, Dr. Stenehjem. I really appreciate you taking the time to talk with us about what's been going on. And like I mentioned earlier, we do have some holiday hours for COVID-19 testing sites. Tomorrow, our sites are open until noon. Conwood Heights Clinic testing site is open until 1 p.m. That's the only difference there. And then all of our sites are closed on Christmas Day. So just keep that in mind. If you have questions around if you qualify for a COVID-19 test, you can go to intermountain.com/COVID testing, answer a couple of quick questions. And if you do qualify, you'll be given the opportunity to schedule an appointment arrival time. We also have our emotional health relief hotline still available 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-5224. If you have any questions at all, you can also head to our website. Dr. Stenehjem, again, thank you so much, and we'll talk with you after the holidays.
Sounds good.